Santosh, Dr. Balendran, Dr. Harikumar, Naushid, and senior pediatricians, and my friends. Today we are launching another action plan, that is Dermatology Made Easy. In this, we are planning a series of talks in the coming weeks. Actually, we had a plan of giving hands-on training at each district. Now she was planning that, but unluckily, COVID came on the way. We are launching another and compensating that through this type of programs. Maybe in the coming programs, we will be able to do more of training sessions in this web platform itself. I thank Dr. Harikumar and Dr. Naushid, the chairman and convener of the dermatology chapter of IAP, for planning this program. And they have contacted the speakers and arranged the sessions. And they have selected 3 good young speakers in Soumya, Nafin, and Shajira. And maybe they have more in store for us in the coming weeks, and they'll definitely make dermatology easy for us. I wish this webinar all the best. Thank you. I invite Dr. Santosh, our immediate past president, to address.
Good evening, everybody. Can you hear me?
Yes.
Yeah, yes.
Today we will be having a dermatology subspecialty chapter conference. The chairperson, Dr. Hari, and Secretary Naushid has done it very well. And 3 eminent speakers are talking to us today. And about Naufina. Naufina is a very good dancer, and she has performed very well in our NNF family meeting, and also in the Coorg meeting we conducted the EB meeting, IAP EB meeting, and we have witnessed her performance. And regarding Shajira Begum, you may not be knowing about her much, but she is from IAP family. You may be remembering who is Dr. Sakaria. He was one of the best secretaries IAP Talasheri has ever had. During his tenure, he has conducted 300 meetings in 360 days. In short, there will be a meeting every day except Sundays. And Shajira is the wife of Dr. Sakaria, our past IAP Talasheri secretary. And regarding the first speaker, I think Harikumar will be elaborating on all the 3 faculties. And they have planned in such a way that all the 3 speakers are given 20 minutes each, and another 20 minutes for question and answer session. And most of the time, these faculties, since they are dermatologists not attached to pediatrics, they do not know what we actually want. So it is a golden opportunity to clear our doubts in the question and answer session. Usually in a dermatology meeting, question and answer session will be more than the faculty speech. So this time also, I expect that you will be actively participating in your question and answer session. I am not taking much of your time. I expect all of you can enjoy a very good scientific feast today. Thank you. Thank you all.
Okay.
Yeah. Over to Dr. Harikumar. Let's say. Yes.
Okay. Thank you, sir. So first of all, at the outset, let me thank Dr. Narayanan and Dr. Balachandran for giving us an opportunity for our dermatology chapter to conduct such a CME session, on Zoom platform. And we have 3 young speakers who have already presented their talks in different national and state conferences. And first of all, let me introduce to you Dr. Soumya Jagadishan. She is Associate Professor at Kochi Amrita Institute of Medical Science. And she will be talking on a rare topic, like rare in the sense we have not had enough on dry skin and associated conditions. So first of all, let me introduce and let me invite Dr. Soumya. Soumya, please present.
Hello, everyone. Thank you, Harikumar sir, for that introduction. Do you want me to start now or after the introduction of all the speakers, right, sir?
No. You just start. No, we will be introducing everyone
Yes.
before the talk. Okay. So I can't put your that slide. Please, can you put that CV slide? And I'm just taking it.
Now,
Okay. Please come.
Hari, now you are sharing screen. Now you.
No. I know that.
Okay.
Okay. You start. Soumya, please.
Okay. You want me to start, sir? Okay. Fine.
Yeah.
So very good evening to one and all. I hope I'm audible to all of you.
Yes.
Please do feel free to stop me anytime you feel I'm not audible or there's any problem with the connection. So good evening. It's indeed a very, very rare privilege to be here with all of you. IAP, I know, is a very, very vibrant academic group of people. So many of you are familiar to me, and also some of my teachers are here. So Harikumar sir had asked me to speak about dry skin and associated conditions. So it's not something that we talk about, like as he said, it's only rarely talked about, because dry skin as such is a very generic thing. Anybody can have it, and dry skin can be associated with almost any of the inflammatory skin conditions. So it's kind of quite general. But I thought I'll just discuss with you a few of the conditions where you are likely to come across dry skin, and the points from a practical aspect of view, from a management point of view, what we have to think about. What I can share with you as a dermatologist, I thought I'll discuss with you. So I've just, clubbed together a few cases, a few scenarios, and a few practical points for today's discussion, because it's practically impossible to kind of talk about all the conditions where dry skin can occur, because it's that common, as we all know. So so this is a case scenario I'm sure you're all come across, and feel free. I want it to be an interactive session, so you could answer. Many of you you could please interact with me during this talk. So this is something which we generally see. An 8-year-old boy, hypothetical situation. I had this case recently. So this is what you see: a large hyperpigmented polygonal scales on the legs. On the legs is what is evident in the picture. He had similar lesions on the extensor forearms as well as the back. So the picture here is, you can see this polygonal hyperpigmented scales here. History goes like it was present since infancy, and father also had similar lesions. Father still has similar lesions, and while he was a child, it was quite mild, but it's more severe as he has aged and become an adult. So what would you think about? What would be the differential diagnosis or diagnosis? Anything simple that you want to think about?
Ichthyosis.
Ichthyosis, yes, absolutely. So since this clinical picture, this clinical phenotype is quite specific, and this is what we call the ichthyosis vulgaris. Vulgaris, as we know, is the common kind of ichthyosis. So just a few learning points about ichthyosis. Ichthyosis is again different from xerosis. Xerosis just means dry skin, whereas ichthyosis, as you know, the term is from the fish, scales of a fish it resembles, and you get these quadrilateral or polygonal hyperpigmented larger scales. So that is when we call it ichthyosis. And it's usually genetic. Sometimes you can also get it acquired. And it is usually associated with abnormal epidermal differentiation or keratinization. I'll talk about it later. So here, basically what happens in ichthyosis is that the barrier function, you know that skin has a barrier function, this gets compromised. So once it gets compromised, the problem is that you will have more transepidermal water loss. That also I'll discuss in the coming slide. So this can be in the neonatal period, you get there are syndromes called as ichthyosis, SES plural, where you get a lot of inherited neonatal presentations, which also some of them I will take up in the coming slides. So this is what ichthyosis means. So these are the layers of the epidermis. I hope the picture is clear. So here what you see is the stratum basale, and the majority of the thickness is contributed by the stratum spinosum. And here, this vertically compressed layer, you have the stratum granulosum, and above that you have the stratum corneum. So a keratinocyte basically journeys from the mitotically active layer, that is stratum basale. It gets progressively transformed to become a spinous layer cell, then it becomes a granulosum layer cell, and then it becomes a corneocyte. So the changes that occur within a keratinocyte during its journey from a newly formed mitotically active basal cell, and as it becomes a corneocyte. So when it becomes a corneocyte, what happens? It gets keratinized. It becomes progressively keratinized, and then it's shed off or desquamated from the surface of your skin. So that journey is called as keratinization. So it's actually a beautiful process. And here I will not really bore you with the details of it, but I want you to get this basic idea that there are a lot of processes happening here. That is in the upper stratum spinosum as well as in the stratum granulosum. There are so many processes happening where these cells are synthesizing lipids. These cells are synthesizing lipids within so many bodies are there, like, the keratohyalin granules and all those things are there. So these Odland bodies are formed, and these lipids are packaged and extruded into the extracellular space of stratum corneum. So when these lipids are synthesized, packaged, and extruded into the extracellular spaces of stratum corneum. So this is what we call the cornified lipid envelope. And this cornified lipid envelope forms the barrier layer of the skin. So it's very important for the integrity of the skin, to maintain the permeability of the skin, and also to regulate a lot of physiological processes in the skin. So it becomes even more important when we talk about dry skin, the conditions associated with dry skin, the treatment from a therapeutic aspect, all these things, this physiology becomes very important. So you know that here I've marked these involucrin, loricrin, filaggrin. These proteins are important here, and you form the lipid bilayer here, and then the scale gets desquamated. I hope that a bit of it is clear. So what happens in ichthyosis vulgaris? Here it's an inherited ichthyosis. It's got an autosomal dominant inheritance. So usually you would have a lot of the family members having a similar dry skin history, but it's not merely dry skin. You would see these actual poly from 3 months to 5 years of age. And as the child grows, it becomes more pronounced. Initially, it may be mild, but it becomes more pronounced. Many of them are associated with atopiform disorders. Atopic dermatitis, we know that usually ichthyosis vulgaris is an association of onset. Early onset evolves with time. Associated cutaneous manifestations like atopic diathesis, you have keratosis pilaris, pumps and soles involvement. The family history is important. You also get typical histopathological findings on skin biopsy, which I will not go into, and also other extracutaneous manifestations. And if in doubt, you can always go for a filaggrin mutation study. But we generally don't do genetic testing for a condition like ichthyosis vulgaris unless there are other associations involved. So how do you treat it? The goals of treatment is barrier repair. As I told you, the lipid barrier is there. So here you need to repair it. You also need to increase the skin hydration and reduce scaling. So for that, we use, for barrier repair especially, we use ceramide containing creams. I will talk about it in more detail a little later. Ceramides are basically, again, constituents. They are part of the physiological stratum corneum lipids. I'm sure many of the medical representatives might be coming to you and talking to you about, ceramide containing creams, justifying its cost and all that. But mind you, many of the ceramides that, you might be seeing, the creams might be pseudoceramides or synthetic ceramides. You have to specifically ask whether it's a physiological ceramide or the pseudoceramide. And also, it might not be present in concentrations adequate to cause any effect. It might only be working as a marketing strategy if it is just a very low concentration. So ceramide containing creams are good, but however, these points also have to be kept in mind. Then since in ichthyosis, you have retention hyperkeratosis at times. That means the scale is not desquamated. So keratolytic creams are also helpful. Again, I will talk about them later. So one thumb rule that we have to think about is when you deal with ichthyosis, the thicker the preparations, the better. So please don't prescribe lotions. Lotions are very watery formulations. So unless you are, dealing with a very sweaty environment or the child is having other, malaria-like issues, please give thicker preparations. There are creamy preparations or ointment. Ointment usually not tolerated well because of the occlusive properties, but thicker the better because they are better used in conditions like ichthyosis. Avoid soaps, contact allergens. Of course, counseling is needed. This being a genetic condition, you have to tell them that you are in there for the long haul and you cannot stop moisturization or any of these precautions for a short term. You have to continue it probably as a lifelong measure. And of course, treat the other comorbid conditions. So that was about ichthyosis vulgaris, one of the most common dry skin conditions you are likely to come across. I hope that part is a bit clear. Please feel free to stop me if there's something which you want me to deal with right now, or we'll take it up during the interactive session. Now, this is another inherited ichthyosis. I'm sure many of you have come across and many of you are much more experienced in dealing with this.
Colloidon. Colloidon baby. No?
Colloidon baby, yes, colloidon baby. So colloidon baby is what this is, and it's not uncommon. And babies are usually born with a shiny, taut, cellophane-like membrane. Colloidon actually is a nitrocellulose preparation, so that term indicates that. And it's actually a common presentation of several congenital ichthyosis. But however, these are the main three ones. So we'll not go into the rare ones. It's either most commonly lamellar ichthyosis or congenital ichthyosiform erythroderma. Congenital ichthyosiform erythroderma, I'm not sure whether you're aware, but it's again divided into bullous and non-bullous. So this is more commonly associated with congenital non-bullous ichthyosiform erythroderma. And also self-healing colloidon baby, which are actually a transient presentation and it will automatically resolve. So the point of interest here is that the presentation is classic. You see this taut cellophane-like membrane, and there is often ectropion and eclabium. Ectropion meaning outturning of the eyelids, and eclabium means you can already see it here. Ectropion and eclabium is classically seen with this presentation. And you don't need to do much about the membrane. After birth, it will become dry. It eventually, sheds off completely within weeks. After which you will get to know what is the phenotype of the underlying ichthyosis, whether it's a lamellar ichthyosis, which is more severe, whether it's congenital ichthyosiform non-bullous type of erythroderma, which is little less severe, or whether it's a transient condition like a self-healing colloidon baby, or whether it's a rarer phenotype like, a Sjogren-Larsen or a syndromic ichthyosis kind of presentation. That you will get to know once the initial presentation and once the colloidon membrane peels away. This is one of our cases. It's a very tragic presentation, but this is called the it's a very specific presentation. This child passed away, as you could make out, but there are reports. Yes. This is the Harlequin ichthyosis. It's called the Harlequin ichthyosis, and we had reported this case actually. But this baby, it was a lethal. This is one of the most severe forms of ichthyosis. One of the most severe forms, and it's because of this in lamellar ichthyosis, it's because of mutation in the transglutaminase gene, whereas this is an ABC cassette binding protein 12 gene. There is a mutation here, And this has got a very Harlequin, you know, Harlequin's meaning that because of that appearance you call it. And here the child is encased in armor-like scales. The scales are like armor. And this thick, very, very thick casing, it develops cracks resulting in deep red transfers and longitudinal fissures. It should be separating these geometric plates of skin. So the presentation is quite classic. In the past, it was universally fatal. Our case was also, it was fatal. However, it is not, you don't have to admit defeat. Times it is possible with intensive support. I'm sure you guys are more familiar how to give support during these times than me, and with specific management, like with the advent of oral retinoids, many of the children, many of the infants were born even as Harlequin. Even with this presentation, they do survive. It does seem little hard to believe, but they do survive. But it's important to identify with the phenotype. So this is a much more mild type of ichthyosis, not uncommon. Again, this is X-linked. This is called the X-linked ichthyosis, where the pattern is X-linked recessive inheritance, and here the problem is a steroid sulfatase deficiency. So here we know that males are affected, and they show cutaneous manifestations usually at birth itself. And it's also called as ichthyosis nigra because it becomes, the scales get darker as the child ages, and it is a kind of retention hyperkeratosis. And it does not desquamate, it gets accumulated on the body. Unlike ichthyosis vulgaris, which had a extensor predilection, here the lesions can be more found on the flexural aspects as well. That's how you differentiate. This can be present at birth. This is more pigmented. This can be present even on the flexural aspect, and it's being X-linked. It is found in males. So findings at birth are fairly mild when compared to other forms. Here the problem, there's something called the other contiguous gene syndrome occurs because the steroid sulfatase gene is located close to a certain other gene. So you might see cryptorchidism, ocular abnormalities like corneal opacities in patients with X-linked ichthyosis. That's also something we have to look out for because we are talking about comorbidities also in ichthyosis. And carrier females, because the steroid sulfatase gene, sometimes the placental sulfatase is also affected. So sometimes these carrier females may also give you history of prolonged. So mother may have a history of prolonged labor because of the affliction of the placental steroid sulfatase gene. So that's about X-linked ichthyosis, quite common again. So this, I guess you're all very familiar, the Netherton syndrome. I hope you're all familiar. This is again an autosomal recessive syndromic ichthyosis. I'm only talking about the ichthyosis which are little common or which have something very different about them. So this is caused by this mutation in the gene SPINK5. It's a very common quiz questions, at least as far as dermatology graduates, postgraduates are concerned. I don't know about pediatrics. So because the presentation is quite classic, you have a triad here in Netherton syndrome. You have an ichthyosiform erythroderma. The skin involvement is in the form of ichthyosiform erythroderma. I hope the term erythroderma is familiar to you. Erythroderma, we mean there is a generalized involvement. That is, more than 90% of the body surface area has redness and scaling. So that's what we mean by erythroderma. So the skin involvement is either in the form of erythroderma, or you could have a very specific presentation called ichthyosis linearis circumflex. I don't want to bore you with the terms, but I have to say it here. This is again a specific presentation where you have double-edged scales. If you see, these scales have two edges. It's a double-edged scale. So if you see these annular lesions with double-edged scale, think of a syndrome, right? So this could be Netherton syndrome. So it's either generalized skin involvement or you have these specific annular lesions. So that is one part of the triad. Second part is the atopic diathesis. They'll have elevated IG, they'll have all the works, asthma, allergy, all those things usually very prominent. And you'll have the third part of the triad is in the hair. Hair, it's very, very specific. It's called bamboo hair or Trichorhexis invaginata, where, you know, the hair will invaginate into each other. So I hope you can see these knots here. So if you do a hair microscopy or if you were to examine the hair closely, you will find that hair is sparse. The child seems to suffer from a bit of alopecia. And when you look at the hair will have knots here. So that is about bamboo hair. So this is what you see in Netherton syndrome, these three manifestations. So again, how do you, in ichthyosis in general, I'm not going into any of the other ichthyosis. There are too many ichthyosis to speak about. That is inherited ichthyosis. These are the main ones you might come across. There are other ichthyosis like a syndromic ichthyosis, where you have neurological manifestations. That could be like Sjogren-Larsen syndrome, where you have spastic paralysis. There you could find ichthyosis. You could find it with Repson syndrome, like phytanic acid tox. You are all more familiar than me about those. You can see ichthyosis with sulfur, Ibid syndrome, all those things, and Rudd syndrome. So many of the neurological syndromes where you have brain involved, the CNS involvement, you could also find ichthyosis. But I think it might be too much to go into the details of the individual syndromes. So in general, how do you diagnose? Mainly by the cutaneous phenotype. So if you see collodion baby, you know that it's either this, or this. So cutaneous phenotype is usually very specific. Or if you see a person with extensor aspect ichthyosic scales and with the family history, you know it is ichthyosis vulgaris. So that is very important. Then skin biopsy is not always helpful. It is only helpful in a minority of cases. So, but you can do it when in doubt, but it's not like skin biopsy is not like a one-stop measure by which you can diagnose a type of ichthyosis. No, in certain cases it might be contributory. Associated findings, like I told you, the hair microscopy. Hair microscopy in case of Netherton syndrome is very, very helpful. Similarly, in certain cases, you might have WBC abnormality. The classical case is something called as Chanarin-Dorfman syndrome. I don't know if you're aware about it. There's something called as Chanarin-Dorfman syndrome. It's a neutral lipid storage disorder where you get something called the May-Jordan anomaly in peripheral smear. So when you see the peripheral, you see lipid droplets within the smear. So that's why these associated findings might also be helpful. And of course, genetic and prenatal diagnosis in really severe cases, especially when you have to do genetic counseling in the real bad case of ichthyosis, to tell the parents, counsel the parents whether the next child will also have the risk. You need to do this. So this is, I guess, important. This is actually not my, doesn't come into my, we don't use it because the neonatal ICU people generally do it. But when you have ichthyosis, these are the things, especially the severe ichthyosis, these are the things that you have to concentrate on. Because normal skin, as we all know, is a barrier against infection. In ichthyosis, the barrier is damaged. So what happens? The child, the neonate or the infant has a high risk for bacterial infection and sepsis. So you have to do all these things. Blood cultures, treatment of infections, topical, and all these things, reverse isolation, all have to be practiced to manage that. And then what is the next problem? Again, skin is involved in the fluid electrolyte balance. It's a barrier against excessive water loss. Here what happens? Again, water loss is increased. You have risk of electrolyte imbalance, dehydration. So here you, again, fluid balance, electrolyte, humidify, all these things becoming IV hydration, all these things have to be monitored. Again, barrier against chemical and mechanical assault. So this is very, very important. You cannot use topical creams that would use in normal uncompromised skin in a neonate or in an infant or a person with inflamed skin. So because then that will absorb and that can cause further complications. And of course, because of this hard casing that sometimes occur, armor-like plates or membranes that occur in ichthyosis, there will be risk of restriction of lung movement or contractures, or compartment syndrome. So all these aspects also have to be looked into while managing a case of ichthyosis. I hope that part is clear. So these are various presentations, neonatal presentations of ichthyosis, which can present as erythroderma, that is generalized involvement, where you have all these possibilities. It can be merely generalized scaling. It can be as a collodion baby, like hyperkeratosis in harlequin ichthyosis, constrictive scales with deformities, or as blisters or erosion. So these possibilities have to be considered. So with that, I'll go to the next case scenario. The second case scenario, it's a very simple, again, a very common case scenario. This is a 10-year-old girl. She has this kind of scaly patch. It's been there since many months. She didn't notice it much and didn't have any itching. It was very asymptomatic. But what happened was that she developed a few other lesions, reddish and hypopigmented lesions over the trunk since 1 month. So she came to me to show that. So on examination, what we found was that over this patch, the sensation was impaired. The other patch, it was almost normal, but this patch, all modalities of sensations were impaired, and there were multiple nerve thickening. So this very innocuous looking, simple, dry, scaly patch turned out to be what? Turned out to be a case of hand. Sometimes what happens is this tuberculoid leprosy patches can be very deceiving. It can just look like a dry patch. It can look like a dry skin patch, and then it can, when you get a lepromatous, when it downgrades into the natural tendency of leprosy, as we all know, is to downgrade. If you don't treat it, tuberculoid leprosy will downgrade from tuberculous spectrum to lepromatous spectrum. So when it downgrades to lepromatous spectrum, you will start developing newer lesions. So it's only then that you realize that you were having a single patch leprosy at times. So this is something we have to think about. Another presentation, common presentation of leprosy, as we all know, is on the face. You get dry scaly patches on the face, the indeterminate leprosy. That again can present as dry skin. Or sometimes you mistake it as pityriasis alba.
Hello?
Mistake it as what?
Hello?
People tell it is nutritional deficiency. But that can also be a indeterminate Hansen disease. So that's one. So here we come to the discussion of acquired ichthyosis. So till now we were discussing about ichthyosis which were inherited, those syndromes and everything. But a child comes to you who didn't have any problem at birth, and then they suddenly develop new onset dry skin or ichthyotic patches. This is usually more relevant in adults, but in children also you may come across this. So there are various causes. So how do you differentiate? The most important thing is, how do you differentiate a mild dry skin, a mere dry skin? Dry skin is like xerosis. It is universal. How do you differentiate that from ichthyosis? I think I already told you the points. One is that ichthyosis has this typical appearance of scales. The phenotype is typical. It is usually more persistent. Dry skin is more transient. As the vagaries of the weather, it will also change. And it will very easily respond to treatment, whereas ichthyosis is more persistent. And by ichthyosis, we generally mean that there is some problem going on with the keratinization process, whereas xerosis is just inadequate hydration, right? So that we have to differentiate, that is one thing. And also, how do you differentiate from ichthyosis vulgaris? Again, by these points. So what are the causes? I think it is one cause that we talked about now, which is leprosy. So infectious disease can always present with acquired ichthyosis. So the one cause is leprosy. And I think there are a lot of causes. Medications are very important, but not very relevant in children other than retinoids. If you were to give an adolescent retinoid for acne, they can come to you with cirrhosis or ichthyosis. Then all these infections can come. Sarcoidosis is actually, I'll come to that in the next. Nutritional disease, again, very, very important cause of dry skin or ichthyosis. Metabolic disease, we know hypothyroidism, any organ involvement can all present with dry skin. Many of the malignancies can merely present with dry skin. So all these are very important causes. And autoimmune disease, inflammatory disease. We have this type called ichthyosiform sarcoid, where they classically present with ichthyotic patches. You will never ever believe that it's sarcoidosis, but it turns out to be so ichthyosis can be very deceiving. You have to be very sure. If in doubt, you always have to do a biopsy. Sjogren syndrome, it's a condition where you have dry everything. Xerostomia, xerophthalmia, xerosis. So again, it's a classical presentation where you get, and other, even the RA, any connective tissue disorders can present with dry skin. It is impossible to write out all the causes, all the conditions which can present with dry. So it's just a very small tabulation that I gave here. And again, hypothyroidism, I always want you to keep in mind, they present with cold, dry, pale skin. So please keep hypothyroidism as a differential diagnosis. If you cannot explain other causes, like if you're sure there is no atopy involved, there is nothing, no medication, and if there are contributory findings, please think about hypothyroidism as well, because you also see hair involvement. You can see eyebrow hair thinning, you can see permanent alopecia in hypothyroidism. Sometimes you see thickening of palms and soles. You can also sometimes see the roughening because of the mucin deposition in skin, or the yellowish discoloration because of carotenemia. So all these things, I'm sure you know more about hypothyroidism than me. So again, look out for these. Okay, so this is a child who had a bit of edema, as you can see, pedal edema, and also had abdominal distension, and whose body weight was much lower than the expected body weight to be. So one thing you have to think about when you see the scales is yes, protein energy. Absolutely, absolutely. So like Jalal sir said, it's in kwashiorkor or protein energy malnutrition. You can get ichthyosiform scales, the classical presentation, what we call the flaky paint dermatosis, all these things. So please keep a DD when you see such presentations. So this would be a case of
Uh, excuse me, Dr. Soumya.
Yes. Time.
Please conclude, please.
Okay. Right. So again, this is pellagra, case of pellagra. Case scenario 3 is again generalized dry skin. I just wanted to bring it to you. History of intermittent asthma, allergic rhinitis, it's just atopy. Most classical presentation is atopy, atopic dermatitis, where you would see flexural involvement classically in this age group. In neonates, you would see, in infants, you would see cheek and all those things, but in here, you would see flexural involvement, toilet seat pattern, pityriasis alba-like pattern. You can see follicular involvement here. Ichthyosis, again, ichthyosis can also be seen with atopy, keratosis pilaris, and all these things. So I think the management aspects, the moisturizers, physiology of skin hydration, all those things I can discuss later. And so I think I'll stop it here. Thank you. Thanks a lot for patient listening. Thank you.
Thank you, Dr. Soumya. So it was a very interesting talk and a lucid presentation. So we will have a lot of questions that we will be discussed in the discussion part. Okay. So next talk is will be by Dr. Nafina Jasmine. She is the consultant dermatologist at PRS Hospital, Trivandrum. And she will be talking on common conditions and spot diagnosis in the OP, pediatric OP, common dermatological pediatric problems. I invite Dr. Nafina to present that.
Thank you, Harikumar sir. Very good evening, everyone. I'm Dr. Nafina Jasmine, dermatologist from PRS Hospital, Trivandrum. IAP is a very familiar platform for me, as Santosh was saying. In fact, the most fun-filled platform I've ever been in. Every member is like so active, enthusiastic, and so encouraging, both in academic and cultural aspects. I feel privileged to have been a part of this IAP Kerala so many times. I thank IAP Kerala and the dermatology chapter for making me a part of this CME once again. So I'm just sharing the screen. Just give me a moment. I'm just sharing the screen once again. Just give me a moment, please. So give me a moment. I'm just not able to share the screen. 1 second.
No problem. No problem. Take your time. Hi, it has come.
Has it come?
Yeah. Just start already sharing.
Okay. Yeah, okay. Today I will be talking on common pediatric dermatological conditions that we encounter in OPD. Basically the salient features of these conditions and how to make a spot diagnosis of these conditions just by looking at the characteristic clinical feature of each of these conditions. And as you all know, there are innumerable pediatric dermatological conditions, but I've just picked the most common ones. And I'm very sure most of you would be familiar with all of these lesions. So to begin with, I have broadly just classified them into infective, inflammatory conditions, and few other conditions. To begin with, infectious conditions, as you all know, they are broadly classified into bacterial, viral, fungal, parasitic. And I want you all to make a guess of each of these conditions. So as I mentioned, the key characteristic features: pearly white papules with central umbilication, or it's called a central punctum, which are dome-shaped and waxy in appearance. It can be single, but usually presenting with multiple lesions. Any guess? That's a case of
Molluscum contagious.
molluscum contagious. Yes. Causative organism being pox virus. Spread is usually direct skin-to-skin contact. It can be indirect also through fomites. In children, most common sites are axillae, sites of trunk, and even on face. And it is rare, usually below the age of 1 year, and perhaps is said to be due to the maternally transmitted immunity and also a long incubation period up to 6 months. Mostly they resolve spontaneously, but they take time and they may even spread. If they're resolving spontaneously, they resolve with inflammation, suppression, and crusting, but they do not leave behind scars. But then you need to treat it to prevent transmission to other sites as well as to other people. So abstain from swimming pools, using swimming pools, avoid sharing towels, communal baths, etc. Now, how do you go about with the treatment modalities? A simple extraction is one modality. Electrocautery or electrodesiccation is a very effective method. Just cauterize the central punctum and try to remove off the molluscum bodies. That is with electrocautery, and something called as phenol cautery. Phenol is a chemical, so it's basically chemical cautery. You use 88% phenol to cauterize the lesion. And depending on the availability of 10% potassium hydroxide, where you can send the patient home with 10% potassium hydroxide, and you can ask the mother to apply it overnight over the lesions. And some studies say that cimetidine, when given in a dosage of 40 milligram per kilogram for around 1 to 2 months, it has shown an immunomodulatory effect on this condition. Okay, next, I think very, very familiar condition. I've just, because it's a common spot diagnosis, I just put up this slide. Vesicles over an erythematous base, given the name dewdrops in rose petal appearance with this characteristic crusted lesion. Once it starts healing, yes, that's a case of varicella or chickenpox caused by the varicella zoster virus, associated with constitutional symptoms like fever, sore throat, myalgia, body ache. Infectious, usually 1 to 2 days before exanthem. And please note, until every single lesion is crusted, the patient is infectious and needs isolation. And something called as breakthrough varicella, it's nothing but a second attack of varicella, and the patient has already had varicella and usually seen only in immunocompromised patients. Treatment: oral antivirals, acyclovir 20 milligram per kilogram 4 times a day, 5 days. Topical antibiotics coverage to prevent secondary infection. And note that there is no role for topical antivirals because topical antivirals cannot prevent the replication of the virus. So there is no point in giving any topical antiviral. Again, another common condition is all there in the picture: erythematous papules, vesicles on the hands, feet, or on the mouth. Yes, that's a case of hand-foot-mouth disease. Causative organism being Coxsackie virus A16, it is a benign illness, takes a benign course until it's caused by human enterovirus 71, where the condition can get fatal because it results in meningoencephalitis. Commonly seen in children, and the fever, URTI can be associated, and self-limiting usually symptomatic management usually would do. Unless there is severe pruritus, then we can give a topical steroid just to bring down the inflammatory component and oral antihistamines. Now, I got a referral from the pediatric department as a case they suspected as hand-foot-mouth disease because the lesions are more on the dorsal of hands and feet as erythematous papules and vesicles. And then they notice the lesions are progressing more towards the knee. And on close examination and on palpating the lesion, it showed that the lesions are not blanching. So when such a lesion is not blanching, we call it as purpura. So more of purpuric lesions are presenting. And the patient, he was a 9-year-old boy, and patient was started developing swelling of joints, abdominal pain, and then later melena. What could be the condition be? And the biopsy showed features of vasculitis.
HSP.
Yes, that's a case of HSP. Okay, the next condition. Hyperkeratotic verrucous growth with brown, black pinpoint lesions on the surface. This again can be single or it can spread to form multiple lesions, viral in origin. It's there in the name, it's a verrucous growth. That's a case of verruca vulgaris, commonly called as what? Vulgaris stands for common. Causative organism, human papillomavirus, again direct or indirect spread as we said in molluscum, and it can even spread at sites of trauma. So the virus gets inoculated at sites of trauma because it's a phenomenon called as Cobnon's phenomenon. It can be multiple, as I mentioned, depending on the immune status of the patient. Recurrence is a very common thing with this condition if it is not treated or removed completely. Again, electrocautery or electrodesiccation, it's a mainstay treatment. Cryotherapy is nothing but spraying of liquid nitrogen, but the only thing is that it has to be repeated multiple cycles. Even topical preparations containing salicylic acid can also be used. So those were the very common viral conditions. Moving on to the next set of bacterial condition. As you all know, Staph aureus is the most common organism causing cutaneous infections. So it can be localized as well as systemic. Localized or common condition presents like this. It can be either bullous lesions or pustules or even crusted erosions. Fever may or may not be present. That is a case of, and neonates, it can be extensive as well. So it's a case of bullous impetigo. And when it presents as thin vesicles and pustules which rupture to form discharge, more of seropurulent discharge, it forms crusting. And this is contagious and more in preschool, school-going children. So that's a case of impetigo contagiosa. Those were the localized one. Moving to the systemic one, ill-appearing child presenting with blistering and desquamation, prone for secondary infection, fluid electrolyte imbalance, and temperature instability. Yes? Any guess? That's a case of Ritter's disease or the Staph scalpel. Yes, SSSS, correct. So the infection source of staph would be conjunctiva nasopharynx or omphalitis, which releases a toxin which is exfoliated, thus resulting in blistering and desquamation. Anti-staph antibiotics like the penicillin groups or the cephalosporin groups, fluid electrolyte balance, and temperature maintenance. So those were the bacterial condition. Moving to the next set, highly pruritic erythematous plaque with very well-defined border. It can occur anywhere on the body. Annular plaque pruritic. That is a case of tinea. grouped under dermatophytosis. Dermatophyte is the organism. So depending on the sites affected, corporis is when it occurs anywhere on the body, as you can see here. Cruris is when it occurs on the groin, and fascia on the face. Tinea pedis when it occurs on the feet, and manna when it occurs on the hands. So these are the characteristic features I mentioned. Erythematous plaques with prominent borders, pruritic. Again, pictures with prominent borders, and it can show moderate scaling as well. This is again Tinea corporis. Tinea capitis is caused by another set of fungus. And again, that can be either non-inflammatory or milder variant or an inflammatory variant. So non-inflammatory milder variant is called as a gray patch. As the name indicates, the hair looks more or less gray and lusterless. This is basically because of the broken off hair, which you can see, and that results in patchy hair loss. Inflammatory component is called as chirion, and that presents as a boggy swelling like this, which can be tender. And when there is associated studded pustules, and which ruptures and leaving behind crusting, it can cause matting of the hair, and this heals with scarring. Treatment, if it is dermatophytosis or just a dermatophytic single lesion, maybe you can try with topical antifungal alone, but for a minimum of 4 weeks. But if the lesions are progressing, rapidly spreading to other sites, you definitely have to give oral antifungal. Tinea capitis, definite oral antifungal treatment is mandatory. Itraconazole dosage would be 5 milligram per kilogram in 2 divided doses. A lesser period would do, like for a period of 1 to 2 weeks for dermatophytosis. But for tinea capitis, you need a longer period of treatment, at least for 4 to 6 weeks. Terbinafine, again, dosage for more than 40 kg, you can give the adult dose of 250 milligram. Less than 40, again, half the dose. Less than 20, half of that. And please note, no topical steroid to be used for any fungal infection, because people tend to give topical steroid just to bring down the pruritus. But if you give topical steroids, as you all know, steroids cause immunosuppression, and that will cause further aggravation of the fungal growth, and it's promoting fungal growth, in fact. Next condition, these are the intertriginous area presenting with erythema, and you can see an element of maceration as well with white scaling. As it is in the intertriginous area, it's called as the intertrigo, and most common cause being candida or the candidial intertrigo. And here we can try topical antifungal steroid combination cream. Usually it's available like mometasone and miconazole combination cream. But give it for a early period of 3 to 5 days, and you have to stop it. This is just to bring down the inflammatory component of the condition. And then it has to be continued with the plain antifungal alone, and again for 4 weeks or 1 month. Oral antifungals only if the lesions are still persisting. So, but make sure it is stopped after a couple of days. Next condition, papules, pustules can lead to scaling, seen more in premature, very low birth weight babies. Again, a fungal condition and often misdiagnosis. This is a case of cutaneous candidiasis. And watch for or check for a white flaky patch in the oral mucosa. And clinical diagnosis, if you are in doubt, you go for a potassium hydroxide mount. You just scrape off one of the lesion and see it under microscope. After adding few drops of potassium hydroxide, you will get to see the yeast and the pseudomycelia. Treatment topicals would have an excellent outcome, clotrimazole or miconazole. Next condition, again very commonly seen, hypopigmented or scaly macules. These are macules, but it has very defined borders. Yes, that is a case of, it can be seen on the face, neck, shoulders. Any guess? And the DD for this would be pityriasis alba. That's a case of pityriasis versicolor. And it can be, pityriasis versicolor, as the name indicates, versi, it can be either hypopigmented or it can be hyperpigmented as well. It can be both colored. So I was mentioning about the DD, pityriasis alba, to differentiate between these two. It's a commonly asked doubt by most of my pediatrician friends. So here the causative reason is like fungal here, and this alba is a form of mild eczema. Both are asymptomatic, and alba is always hypopigmented, and versicolor, as I said, it can be hypo or hyper, and it has scales. And in alba, very minimal scaling is seen. It's not usually evident. Defined margins. That is a very important differentiating point. And absolutely no erythema would be seen in versicolor. Alba may have some erythema component, and alba is always usually on the face. This can be on the trunk as well, and atopy association can be seen in alba. You can diagnose as fungal scraping of the lesion for P versicolor, and seeing under the microscope, as I mentioned earlier, with potassium hydroxide, it will show the yeast and mycelia. And if the instrument is available, that is called the Woods lamp, it fluoresces as the pityriasis versicolor lesion. So these two are the diagnostic modalities. Again, topical antifungals would do for versicolor. For alba, just reassurance, self-resolving condition, this emollients would do. If at all there are active signs of inflammation, you can just try a mild topical steroid like hydrocortisone. Those were the fungal condition. Again, a very common condition in children, extremely pruritic, excoriated papules, characteristic burrows seen in the characteristic sites, which are the web spaces, the genitalia, periumbilical area. And that is a case of anybody?
Scabies.
Causative organism being the Sarcoptes scabies, mite, intense pruritus and family history, two important history. The larvae of these mites, they emerge into the skin and they form these small pockets, and these are called as the burrows, which you can see here. And close contact of at least 15 to 20 minutes is required with the infected person is required for the transmission of this infestation. Treatment, permethrin 5% cream is a very effective modality, and how it has to be applied has to be kept in mind. And overnight single application of this cream and the repeat application after 10 days is what we do. The timing, you can ask for the overnight application at 10 p.m. in the night, and it has to be washed next day at 8 a.m. It has to be applied that long and has to be repeated after 10 days. Now the quantity, depending on the age and the weight of we use the entire tube. So for smaller kids, we usually use half the tube. Little bigger kids, you can even use the like 2/3 of the tube. So depending on the size of the patient. And oral tablet ivermectin. Usually, ivermectin is not prescribed below the weight of 15 kg or below 5 years, that's what we say, in a dosage of 200 micrograms per kilogram. It is available as 6 milligram tablets as well as 12 milligram tablets. So as depending on the weight, we can adjust it. Like you can take the 6 milligram and make half of it and make it 9, 6 plus 3, and can give accordingly. Blanket therapy is very important. There's nothing but treating all the family members with a similar treatment. So next, I'm moving on to inflammatory condition. These are typical lesions, deep-seated vesicles seen in patients or kids with hyperhidrosis, palmoplantar hyperhidrosis or excessive sweating, given the name sago grain appearance. This is a condition called as Pomfolix or dyshydrotic eczema. It's a type of eczema. Treatment, topical steroids can bring down inflammatory component, but if it's very extensive and very pruritic, you have to give a short course of oral steroids as well. A very important topic, I think, for all the pediatricians. The patient will be presenting with lichenified, hyperpigmented, scaly plaques, mostly affecting the flexural area, or flexural lichenification with pruritus and personal or family history of allergy, asthma, or atopy. Yes, that's a case of atopic dermatitis. And as you all know, there are various phases for it. Infantile phase, when the age group is up to 2 years, childhood phase till puberty, and adult phase after that. And childhood phase lesions and adult phase lesions are more or less similar, more of lichenified plaques on the flexural component. Whereas in infantile phase, it involves more of the extensor aspects like elbows and face involvement, cheeks and forehead. And here, plaques are seen in childhood phase, more of papilla lesions are seen in the infantile phase. And also it said that it spares the diaper area. And it's said to be perhaps due to increased hydration or because of increased moisture in the diaper area, because more dryness will flare, exacerbate atopic dermatitis, but diaper area is more moisture. And also it protects from aeroallergens. So that is why it's said to spare the diaper area. Emollients, very, very important for any case of atopic dermatitis. Topical steroids to bring down the inflammatory component, the eczema part. And as we cannot continue topical steroids for a longer time, it can be replaced with topical immunomodulators like tacrolimus. And very severe acute flare-ups, you have to go for a short course of oral steroids as well. Very common rash, erythema and greasy scales on the intertriginous areas, neck, and scalp, most commonly affecting the scalp, and it's called the name cradle cap. That's the case of seborrheic dermatitis. Yeah, and please know that a fungal element plays a role in seborrheic dermatitis, Malassezia furfur. And hormonal fluctuations at these do play a role because it's seen in sites where there are high density of sebaceous glands. So hormonal fluctuations also do play a role. And self-limiting, though you can try these remedies like soaking the scalp overnight with just oil, then shampooing it every day, next day with mild shampoo, and removal of these scales when it's with a soft brush, but not vigorously. And as Malassezia furfura fungus has a role, topical antifungal creams have to be used. And because of the inflammatory component, a mild steroid like hydrocortisone bisphenic can be added. So those were the eczematous conditions, Pompholic, atopic dermatitis, seborrheic dermatitis. This is a very interesting condition actually. People often misdiagnose it with drug rash or food allergy, and they miss the diagnosis given the name breakfast, lunch, dinner pattern. Because it is in a linear pattern, if you closely observe these lesions, you can see small punctum at the center of each lesion, which corresponds to nothing but a simple insect bite reaction, a very commonly seen condition. And breakfast, lunch, dinner, it's given the name because it goes for the breakfast, insect shifts and goes for lunch and then goes for the dinner. So I'm just moving on to next few other common conditions. I think everyone is so familiar with this condition. Pearly white yellow papules on the face, like cheeks, nose, anywhere else, forehead also, basically because of retention of the keratin. Yes, that's the case of milia. And important DD for milia is this condition. Any guess? Particularly on this area, nose, perinasal area, perioral area. That's an area rich in sebaceous gland. And this is because of the hypoplasia of the sebaceous glands. It's a case of sebaceous hypoplasia. Both disappear spontaneously, nothing to be done, benign self-limiting condition, just simple reassurance would do. Again, very, very commonly seen erythematous papules, vesicles with mild erythema, usually on the covered areas. And people call it as prickly heat or the heat rash. This is a case of miliaria due to obstruction of the sweat duct. So warm weather and fever are the predisposing factors. Again, this has variants rubra and crystallina. Rubra stands for red. This is the commonly said one as heat rash or the prickly heat. Crystallina, as the name indicates, crystal, so it doesn't have the redness, so it's more of vesicles. Again, crystallina, rubra, and the third variant is pustulosa. It presents with more of pustules. This can be like a little confusing with the congenital cutaneous candidiasis I was talking about. Again, go for the KOH and you'll get the diagnosis. Management, heating, overheat is the problem, so avoidance of overheating. So that can be done by removal of the excess clothing, cooling baths can be given, and keeping the rooms air conditioned. Pigmentary condition, again, quite commonly seen. These are nothing but birthmarks or nevi. Both have similar picture, but both are different. One is nevus depigmentosus, other one is nevus anemicus. Now, how do you differentiate between the two? You go for a test called as diascopy test. This is nothing but just with the help of a glass slide, you just apply pressure on the lesion. If it is nevus anemicus, it blends with the surrounding blanched skin. Whereas if it is nevus depigmentosus, it does not blend. And this is basically, deep pigment is basically because of the failure of migration of melanosomes, and the anemicus is because of the sensitivity of the hypersensitive blood vessels to catecholamines. Just camouflage creams can be given, or later on you can go for some cosmetic grounds. With next condition with the characteristic lesion called as a wheal, which is nothing but raised edematous transient lesion, severe pruritus and erythema. This is a case of
Urticaria.
urticaria. And here the edemas in epidermis and the dermis. If the edema is extending to the subcutaneous tissue as well, causing periorbital edema or perioral edema, then it is angioedema. Antihistaminics can start with non-sedative, still persisting, add on a sedative, is still persisting, you can updose the antihistaminics, both sedative and non-sedative. And associated with angioedema or very severe acute flare-up, you can give a short course of corticosteroids, but make sure if you're finding out the trigger, avoidance of trigger is very, very important. Follicular keratotic papules more seen on the extensor aspect of elbow. Previously said to be because of vitamin A deficiency alone, but it is a deficiency of vitamin A, essential fatty acid, vitamin C, and vitamin E. Yes, that's a case of just on the elbows, is more commonly seen in the elbows. That's a case of phrinoderma. Again, topical emollients can be given and multivitamin supplements because of deficiency of multiple vitamins. Next condition, a papulosquamous disorder. Papulo means, the papules, squamous means scaling. So this has a characteristic papules and with peripheral collarate of scale, like collar-like scales. And most of them are papules, but you can see a single bigger patch somewhere on the body. And that patch is called as a herald patch. And it's also given the appearance name as Christmas tree pattern. Any guess? Herald patch seen in which condition?
Pityriasis rosea.
Yeah, it's the case of Pityriasis rosea. And the Christmas tree pattern, which I was talking about, from above down, you can see the branches, how it goes. And similarly, the line of the lesions, just like that. Viral origin, that's what they say. Upper respiratory tract infection may be associated, self-limiting, but we try a course of azithromycin because it's said to have an anti-inflammatory action as well as an amount of antiviral action as well. And topical steroids can also be given. Usually it's self-limiting, goes off within 6 to 8 weeks. A disease of keratinization with the typical hyperkeratinized or hyperkeratotic erythematous scaly plaques affecting the extensor aspect of the body. And these are the common sites: elbows, knees, lower lumbar area, and the scalp.
Excuse me.
Any guess?
Nafina, please.
It's just one more condition. That's it.
Yeah.
That's a case of psoriasis. Again, topical steroids, emollients, and phototherapy is also one mode of management. A linear dermatosis following Blaschko's lines and usually limited to one side or any one limb, like lichenoid papules. This is often a referral I get from the pediatric department, and it can even involve the whole of limb. This is a condition called as lichen striatus. Self-limiting, spontaneous resolution in 3 to 6 months. Again, that is a case of lichen striatus. Emollients would do, nothing much to be done for this condition. And this is a case of, again, hyperkeratotic follicular papules similar to phrinoderma, but it can occur anywhere on the body. That's a case of lichen spinulosus. Since it's hyperkeratotic lesion, you can give keratolytics. These are the keratolytics like salicylic acid ointment or topical retinoids. This is the last condition. Patchy hair loss. Patchy hair loss, it can be single patch or it can present as multiple patch. This is an autoimmune condition, as alopecia areata. Unlike other reasons of generalized hair fall, here the reason is autoimmune origin because of the perifollicular lymphocytes aggregating on the follicular area, which hinders the growth of the hair, leading to patchy hair loss. You have to give topical steroids And the more effective treatment is you can give a shot of intralesional steroid also, which works faster, maybe once in 3 weeks or once in a month injection of triamcinolone, dilution of 2 to 5 milligram can be given. Multiple lesions, you have to give oral steroids because autoimmune origin, and even phototherapy helps. So those were the other conditions, melia, miliary, alopecia, and these conditions, urticaria, rosea, phynoderma, psoriasis. Thank you.
Okay. Thank you, Dr. Nafina. It was a wonderful talk. And our next speaker is Dr. Shajira Begum. She's consultant dermatologist at Indira Gandhi Cooperative Hospital, Palisheri. So, Nafina, please stop sharing. So, she's now I invite Dr. Shajira for the talk.
Okay, sir. Am I audible,
Okay,
sir?
you can start. Yeah.
A very good evening to one and all. First of all, I thank all the organizers for giving me this opportunity. Newborn skin, what is normal, what is abnormal? We can make it full. Full screen. Even though the newborn period is a very short period, we have so many skin conditions which are just physiological, or some of which are transient, or some conditions which are fatal by itself, or it have so many systemic complication or association. We can have a look through the skin physiology. It is not working. Slide. One minute, sir. The weight of neonatal skin is 13% as compared to 3% of in adult. The functions of the skin are the barrier function, which is normal to adult in a term baby, but it is impaired in preterm babies. It has a good role in thermoregulation, which is very important for the newborn, and it prevents transepidermal water loss, and it has a good role in sensory perception. Coming to the physiological condition, the physiological conditions are usually seen and dealt by you people than by us, the dermatologists. We have a look through vernix caseosa, superficial cutaneous desquamation, sucking blisters, neonatal occipital alopecia, sebaceous gland hyperplasia, milia, acrocyanosis, harlequin color change, cutis marmorata, and Epstein's spurs. Now we can see the cyanotic limbs of this baby, which is the typical of acrocyanosis. We can see the peripheral cyanosis in a full-term newborn, which is marked on palms and soles and also around the mouth, which is more pronounced in hypothermia and also in hyperviscosity syndrome. The vernix caseosa, we can see creamy white biofilm on the body of the baby, which is more on the face and flexures, which has antimicrobial properties. The color may indicate intrauterine problem, that is fetal distress, or yellow color may show hemolytic disease of the newborn. Now, this baby has a discrete discoloration or color change of right and left half of the body. Anybody can guess? Which is a harlequin color change, which occurs during first week of life, occurs when baby lying on its side, which is erythematous flush with a sharp demarcation line showing subsidence within seconds to 20 minutes each episode. And it shows immaturity of autoimmune vascular control. If it persists beyond 1 month, we have to rule out cardiovascular anomalies. And this is another color change seen in newborn period. You can see the marbling appearance of the skin, which is typical of cutis marmorata. This is also physiological. Benign cutaneous vascular phenomenon may be seen throughout infancy, which disappears when the baby is rewarmed. It is an exaggerated vasomotor response to hypothermia. And if it persists beyond infancy, we have to look for hypothyroidism or trisomy 21 or De-Lange syndrome. Sucking blisters are nothing but blisters due to the vigorous sucking of the baby in utero. Usual sites are radial forearm, wrist, hand, and fingers. And milia, as Dr. Nafina covered, it is the pearly white papule seen on the face. If it occurs in the oral cavity, it is known as Epstein's pearls, which is also just physiological, resolves spontaneously over a few weeks. This is the Epstein pearls, which is seen in the oral cavity. Sebaceous gland hyperplasia is also, it is due to sebaceous overactivity of the sebaceous gland due to maternal hormonal influence, which are seen as yellowish macule or papule at the pilosebaceous sites. Nose and central forehead are affected, resolve spontaneously. In this, we can see the peeling of the skin of the foot, which is just physiological superficial cutaneous desquamation occurring in 75% of newborn, may confine to hands and feet. Maximum peeling occurs by 8th day. One differential diagnosis is ichthyosis vulgaris, which is seen. In this, we can see severe scaling and generalization. The other end, next one is neonatal occipital alopecia. There is loss of hair at this occipital area. It is due to difference in hair cycle at frontal and occipital area. That means in utero itself, there is a telogen or hair shedding phase starting from the 5th month onwards. It starts from frontal area to occipital area. So in utero, it starts from 5th month from frontal to occipital. It reaches at the occipital area at term or near delivery. And immediately after delivery, we can see the hair shedding phase at the occipital area. That is, there is no hair or shedding of the hair at the occipital area. There is no influence of maternal.
Hello, there is no.
There is no influence of pressure or friction or heat. Then transient dermatosis, which are dermatosis, which are physiological. It may last for 1 month and which are of non-infectious origin. The conditions are erythema toxicum neonatorum, neonatal acne, miliaria, transient neonatal pustular melanosis, infantile acropustulosis, subcutaneous fat necrosis, and sclerema neonatorum, and eczemas also. So in this, we can see a blotchy erythema and also erythematous papules over the abdomen and also in the axillary folds and forearm. This is typical of erythema toxicum neonatorum or toxic erythema of newborn, which is in this case, baby is well unperturbed, occurs within 48 hours of after birth, and which is, as I said earlier, transient blotchy red macular rash distributed mainly on trunk, face, and proximal limbs. The lesions would not occur on the palms and soles. the cause is unknown, which has an association with blood eosinophilia, which fade within 1 to 3 days, can recur. In this, we can see pustular lesions and also hyperpigmented macules. This is transient pustular melanosis. That is, it is transient as the name indicates. Pustules are there and it subsides with a melanotic color, which is also unknown etiology. In this, the pustules are fragile, superficial, and there is no erythema as in the case of erythema toxicum. The usual sites are chin, neck, forehead, back, and buttocks. The lesion rupture
ബാലേന്ദ്രൻ കയറി കുഴപ്പമില്ല.
colored scale on a pigmented macule. Pigmentation persists for 3 months. Biopsy of pustule shows neutrophil and eosinophils as compared to the erythema toxicum. In that we can see eosinophils. This is also a self-limiting condition. In this, we can see pustular lesion over the soles. It's also common in neonate. Anybody can guess?
Scabies.
Yeah, no, it is infantile acropustulosis. It is a differential diagnosis for the scabies in the case of newborn. It occurs recurrent crops of intensely pruritic vesicular pustules in the acral distribution only. But in the case of scabies, the lesion occur generalized, especially in the newborn. It can occur on the face and full body. Onset within first 6 months. Each crop lasts for 7 to 14 days and recurrence usually by every 2 to 4 weeks. This is, as I said, it is intensely pruritic, so it may need potent steroid itself, the topical steroid itself, or dapsone is tried in severe cases. But it is a spontaneous, it has spontaneous and complete remission by 2 to 3 years of age. This is, we can see scaling and also clear vesicles, and also in this we can see erythematous papules, which are typical of malaria. Malaria is due to obstruction of the sweat duct at different levels. It has several names: malaria crystallina, malaria rubra, and malaria profunda. Malaria crystallina, the vesicles, there will be occurrence of clear vesicles, obstruction at stratum corneum, seen on the forehead, scalp, neck, and upper trunk, rupture forming brand-like desquamation. That is the case we have seen in that picture. And malaria rubra, there is erythematous papules and papullovesicles. In the block is at the mid-epidermal junction, which subsides in 2 to 3 days, improves if predisposing factors are removed. And next condition is we have diffuse, discrete erythematous nodules. We can see on the back of the baby and also on the front. This is seen in discrete erythematous nodular lesions on the trunk and limbs of the baby in a well-term baby, which is the subcutaneous fat necrosis of newborn, which is seen in subcutaneous fat necrosis of newborn, which is seen in full-term or post-term neonates of normal weight. Sites are buttocks, thigh, shoulders, back, cheek, and arms. As I said, discrete, hard, reddish, violet nodular lesions can be seen, associated with hypercalcemia and spontaneous resolution over weeks. But there is another condition called sclerema neonatorum, which is a gravely ill condition, which is seen in preterm neonates in first week of life. The lesion first start in the lower limbs, then getting generalized, causing an expressionless face and woody skin induration with immobility. In this, we have to treat the underlying condition, exfusion, and IVIG may be needed. This is the case of sclerema neonatorum. You can see the diffuse induration of the skin of the back of the baby. Eczemas. The neonatal eczemas include, which are mostly transient, Some may be chronic and severe, as in the case of atopy. It may be a clue to internal diseases such as acrodermatitis enteropathica or Wiskott-Aldrich syndrome. There are 3: infantile seborrheic dermatitis, primary napkin dermatitis, and perianal dermatitis. Seborrheic dermatitis, you can see the scaling of the face with erythema of the face, which starts on 2nd week to 6th month of baby, which is usually scalp, face, and proximal flexures are involved, which can be a part of atopy. There is no increased evidence of seborrheic dermatitis in adult, which has a favorable prognosis. And most common presentation is cradle cap, that is greasy yellow scaly plaque in background of erythema, and there is occurrence of erythema and scaling in other seborrheic areas. Pathophysiology, there is an association with the malassezia infection. There will be spontaneous remission. In the scalp and forehead, we can see the greasy scale. Differential diagnoses are intertrigo, disseminated primary irritant dermatitis, atopic dermatitis, and primary immune deficiency. Next one is primary napkin dermatitis, which occurs 3rd to 12th week of baby, which seen as confluent erythema of convex surface with peeling of the skin. In this, we have to note the deep flexural sparing, which is seen with cannulal trigo, and is associated fungulation, which can be due to maceration by water or moisture, friction, urine degradation products, or irritant effect of feces, which can also be due to misguided skin care by the parents, use of antibiotic, and also it is caused by due to diarrhea. It usually, a striking feature is post-inflammatory hypopigmentation. Parents can present with this post-inflammatory hypopigmentation to us. We can see these lesions as this is a mild form of napkin dermatitis, and in this there is severe involvement of the thigh and lower abdominal wall also. The variants are Jacquet's dermatitis, which is an erosive form, and there is an infantile gluteal granuloma, which is a nodular form, and it may be a first sign of atopic dermatitis or seborrheic dermatitis. The differential diagnoses are neonatal candidiasis, congenital syphilis, acrodermatitis enteropathica, and Langerhans histiocytosis. As I said, neonatal candidiasis, there is involvement of the flexures. In congenital SY, systemic association. Acrodermatitis enteropathica, other flexures are also involved, perioral area, palms and soles and all. In Langerhans histiocytosis, also systemic association, and also lesion can occur with a hemorrhagic lesion, you can see. The management part, highly absorbent napkins with added breathable microporous film can be advised to the parents. We have to ask for frequent change of the napkins, and routine care with soapless soaps should be advised. Use of tar and other OTC products should be avoided. Special treatment we have to give we may have to give topical steroid, that is mild steroid only, hydrocortisone 1% to decrease the inflammation. So we will move on to the next topic, nevi or developmental defects. Mongolian spot, salmon patch, infantile hemangioma, congenital melanocytic nevus, sebaceous nevus, verrucous nevus, and aplasia cutis. Now we can see the hyperpigmentation on the back of the baby, which is usually the most common site for Mongolian spot, which is also known as dermal melanocytosis. Macular blue-gray pigmentation, which disappear during childhood, Persistence is seen in mucopolysaccharidosis. Multiple spots in widespread distribution can occur in Sjogren-Larsen syndrome. Infantile hemangioma, which is a vascular tumor, most common tumor of infancy, which is seen in 5 to 10% of infant period, which is of 3 types: superficial, which is known as strawberry angioma, deep type, and the mixed type. 2 phases are there for the development of hemangioma. There is a proliferative phase for the first year and then an involution phase of 3 to 10 years. The complications are ulceration and bleeding of the lesion. And there is association with phase syndrome. Salmon patch, which is also known as stork bite or angel kiss, which is a vascular malformation. In contrast to the other one, it is a vascular tumor, which is seen as irregular pink or red patches with or without telangiectasia. Usually on the nape of neck, it is known as stork bite, and the forehead, it is known as angel's kiss. Facial lesion subside within 1 year, or sacral lesion can be associated with spinal dysraphism. And if with secondary abnormalities such as lipoma, hypertrichosis, or hemangioma, we have to do USG or MRI. Potvine stain, which is also a vascular malformation, seen as macular telangiectatic patch, present at birth, remains throughout our life, commonly seen on the face. Treatment is pulse dye laser. Association is Stooge-Weber syndrome, that is Potvine stain with ipsilateral vascular malformation of eye and meninges. This is, we can see a allopathic patch at the scalp, which is the common site for nevus sebaceous, that is, which is a circumscribed hematoma of the sebaceous gland, which is solitary, hairless, or greasy orange-yellow plaque. Later may become verrucous or nodular. Association nevus sebaceous syndrome, that is this nevus with multiple anomalies of the skeletal, ocular, and kidney. And there is a chance of malignancy. There can occur trichoblastoma or basal cell carcinoma. The treatment is full thickness excision. There is also an association with hypophosphatemic rickets. So in resistant rickets, we can have a look at the scalp, and if there is a lesion, in the book it is saying there is liberation of hypophosphatemic thing in the blood. Congenital melanocytic nevus. You can see the black large nevus on the back of the baby, which is seen in 1% of newborn. There are 3 types: giant, more than 20 centimeter or more than 5% of the body surface area; small, less than 1.5 centimeter in diameter. That is, the giant one is more than 20 centimeter in diameter, and intermediate in between. The sites are lower trunk, upper back, shoulders, chest, and proximal limbs. The morphology, it can be flat, elevated, verrucous, nodular, with various shades of brown, blue, or black. There is a chance of malignancy in the small variety, that is less than 1.5 centimeter. There is very, very rare chance of getting malignant. But in the giant variety, that is, it is more than 20 centimeter, or if it is associated with satellite lesion, or it may be associated with the leptomeningeal melanocytosis, there is high chance, that is 5 to 15% chance of malignancy. Verrucous nevus, we can see verrucous lesion on the face, which start as a macule, then it will later become a papular lesion. Usually it occurs on the lines of Blaschko, that is linear streaks, which can be flesh-colored warty plaques along the lines of Blaschko.
Excuse me, Shajira, how many slides you have more?
I have 25 more. So
25 more. No, you should conclude now, okay? So
Okay.
take 5 more minutes, okay?
Okay, I will show the important one, okay, sir.
Okay, fine.
Anyone can diagnose this. We can see a lesion in the face. It is an infection, that is bullous impetigo. It is a staph infection. And another one is, we can see the scalded baby, that is staphylococcal scalded skin syndrome. The fungal infection, there is neonatal candidiasis and also congenital candidiasis. We can see the severe form of congenital candidiasis, that is occurring through the ascending infection through the genital tract. And the viral infection, we have neonatal herpes simplex virus infection. That is, we can see the eroded lesions on the back of the baby, which can occur intrauterine or from the genital tract also during delivery, which have skin or mucosal lesion, which may have. And fetal varicella syndrome, which in this also we can see the erosion and hypoplasia of the lower lip, fetal varicella syndrome, which occurs during when infection occurs at 5 to 20 weeks of intrauterine gestation. Congenital rubella, we can see the blueberry muffin baby, and also IUGR, microcephaly and microphthalmia. Then some genodermatosis, ichthyosis, already Soumya doctor covered. And incontinentia pigmentae is a linear lesion seen in the newborn baby, that is seen as erythematous vesicular lesion along the lines of Blaschko, healing with hyperpigmentation. Then epidermolysis bullosa, if there is a spontaneous occurrence of blisters at the site of friction, we have to think of epidermolysis bullosa. It is an inherited disorder. And we can see an aplastic area here. This is aplastic. This is the blueberry muffin baby. That is, we can see the indurated purpuric nodules on the scalp and body of the baby, which occurs in congenital infections, hematological, drug-induced, and neoplastic condition. There are some iatrogenic cutaneous lesion in this new era. We have so many sophisticated things to diagnose and treat the baby. That is, there is antenatal, there is punctate scars on the body. Gangrene of the anterior abdominal wall is reported with intrauterine blood transfusion. During delivery, due to forceps, local fat necrosis, and at the site of vacuum, there is permanent alopecia. At the site of scalp blood sampling, cephal hematoma, and osteomyelitis. And the complications of phototherapy, as you all know, there will be darkening of the skin. And in hepatic impaired babies, we can see a rare syndrome called bronze baby syndrome. That is dark gray brown pigmentation of skin, serum, and urine. Then some neonatal emergencies are neonatal erythroderma, that is primary and secondary. Primary without any cause, and secondary usually due to ichthyosis. And genodermatosis, I told, epidermolysis bullosa, if it is severe, it may be a neonatal emergency. And the collodion baby and SSS may become a neonatal emergency. Thank you, sir.
Thank you, Dr. Shajira.